All right. Good morning, everybody. I'm Grant Schulert. I know most of you actually in this room, and this is Chris Towe, who's a pediatric pulmonologist also at Cincinnati Children's. And so we're going to talk some about our experience managing these patients in Cincinnati.
Can you make sure your phones are off if they're on, please?
Don't text and talk at the same time.
No.
And so I think hopefully we can start to maybe provide some pearls of wisdom of what we're doing and seeing. I think both of us are spending more time on each other's worlds than we ever thought we would, as I'm understanding lung pathology, which scares me, and Chris is becoming an amateur rheumatologist. So our disclosures that we start with, and I think Chris is the much more relevant one, which is that he's not a rheumatologist, and we're going to be talking a lot about radiology and pathology, but we're neither of those things either. So I'm going to start with a couple of slides just broadly about our experience at Cincinnati and the patients we've taken care of, and then we're going to go through in a bit more detail 3 stories of patients where we've been extensively involved in them and where there are similarities and differences, and then some lessons that I think we've learned that I think are informative as we care for these patients. So I put this slide together in the summer initially, and I've already had to update it, unfortunately. So this is just another way of looking at this increasing incidence. The circles are going back, and in that calendar year, the number of patients that were seen in that year with sJIA as well as interstitial lung disease. And then the triangle, that's a triangle, are the number of new patients that we've seen in Cincinnati who had never been seen prior in Cincinnati. And so this year, it's now 4 that we've seen this year. And this is a mix, right? So there are really 3 groups. There are local patients that were diagnosed with their initial disease in Cincinnati and have since developed lung disease. There are transplants, as I would call them, who were diagnosed elsewhere and have now come and are now primarily managed by us in Cincinnati. And then there's also been several second opinions who have had sJIA plus or minus lung disease when they came to us for a second opinion. And then this is a bit more granular detail on those patients and a couple of patterns that jumps out from this. One is that there are a couple with trisomy 21, which we're going to talk more about. Number one is if Vivian was talking about these 2 patterns of disease, and we've seen that as well. But what's interesting is that if you look at the ones that have, you can't really see that, can you? Oh, yeah, you can. Oh, good. The ones that have biopsies, all of the ones that have been biopsied either by us or by one of our colleagues elsewhere have PAP. And so I think that I would bet that a majority of those ones in group 3, if they had biopsies, would find features of this proteinosis-like thing. And then Alexi referred to this data yesterday, but how prevalent is this? So we tried to make a best prevalence estimate. So I went into our database and made a definition of what I called an actively followed systemic GIA patient, which was someone who had either was seen in the last year by us or has an appointment already scheduled to see us some point soon, as patients who are actively being managed by us. And with caveats, right? So this may be a high number, right? Some of these patients maybe have been second opinions. They weren't ones that came here. And some of them were these ones who've come elsewhere, so there's some selection bias, but also maybe slightly low, right? It's a registry. Many patients in the registry are not coded or coded as undifferentiated or something. However, if we take this number of 70 and the patients that have developed lung disease, it gives us a prevalence of maybe 5%. And I think Chris and I are both afraid that this is the tip of the iceberg. So we're going to then start these cases here. So the first case, which we're going to call typical sJIA lung disease with a twist. So this child was 22, is now, when they came to see us, it's a 22-month-old female with sJIA, born with trisomy 21, had an AV canal that was repaired, G-tube dependent since infancy. At the age of 7 months, had an episode where developed recurrent episodes of quotidian fevers, along with a classically described systemic evanescent rash, but no arthritis. couldn't figure out what this was, but then developed a second episode which had features of MAS with anemia, thrombocytopenia, high ferritin, very high soluble IL-2 receptor. Had a bone marrow biopsy that did show this histiocytic expansion, but not overt hemophagocytosis. Had normal functional NK cell testing, normal HLH genetics, and was started on anakinra for presumed MAS. And this is a child who was diagnosed originally in Birmingham. And continued on anakinra, and it required pretty significant dose escalation. Was ultimately getting, when we first saw her, the full 100 milligrams twice daily. But despite this therapy, had 3 additional hospitalizations for MAS, had been placed on cyclosporin, and was also chronically steroid dependent. And anytime they tried to wean that steroids down, this child had further flares of her underlying MAS-like disease.
They called me because of what we saw later, and we got a chest CT on, and looking back in her history, she'd actually had a chest CT at the time she was diagnosed at 8 months of age, and she had some small pleural effusions and some mild airspace disease. She got RSV a month later when she was transiently on oxygen, and an RSV patient on oxygen for a week is nothing too significant in a 9-month-old. But then it was at 13 months she was found to be hypoxic in clinic, and that's when they started her workup, and the CT scan was quite abnormal even then, with diffuse interstitial thickening and patchy alveolar opacities. They did a sleep study, which I'll have to apologize for my acronyms. So the overall apnea-hypopnea index is only 0.3 in this child, and their REM, so rapid eye movement dependent apnea-hypopnea index. So while in dream sleep, the AHI goes up, and it was 1.2, and so that barely is probably the minimalist criteria to ever diagnose somebody with obstructive sleep apnea. And with that, they started the child on oxygen and titrated it up to 3/4 of a liter nasal cannula just on this. They did a bronchoscopy, and this is where some of the overlap gets really confusing between managing trisomy 21 patients and managing trisomy 21 patients with interstitial lung disease, because the child did have evidence for obstructive sleep apnea by bronchoscopy. The BAL, though, was relatively unremarkable. The echo was unremarkable for someone who had heart surgery. And so they chalked her oxygen needs at that time up to obstructive sleep apnea. And so that was at 13 months of age, and like Grant said, we saw her when she was 22 months old. And over that time, her oxygen requirement had increased to where now she was on 1 liter during the day and 1.5 liters at night, and nobody had gone back to address the underlying what this was. It was clearly not obstructive sleep apnea. And whenever she came off oxygen, she would desaturate into the 80s. She had persistent apnea at baseline. She did snore, so she may have sleep apnea. And her exam, had some tachypnea, had fair air entry. It was mostly a 22-month-old screaming in my face, actually, because she was mad at me. But she did have this erythematous, you can see it from across the room, 4+ clubbing that a lot of these patients have. And so this is her chest CT scan. I will apologize, I do not follow the child recommended guidelines, I must admit, in that I don't do a lot of sedated inspiratory chest CT scans. And that's a practical limitation. 1, because the kids I scan have lung disease, and so sedating anybody with lung disease is a risk. And 2, it means that I can see the child in the clinic in 1 day, and then get a CT scan the next hour, and see the child in clinic 90 minutes later, and actually tell them what they have, as opposed to planning for a scan 2 weeks in advance. And this kid was seeing us, from out of town, so it made sense practically to just do it. And even though there is motion artifact and it's not pretty, you probably can't publish this on the front cover of a journal, you can clearly see that this is an abnormal chest CT scan. And that's the other thing we've learned by doing these kinds of chest CT scans, is for 90+% of cases, we can get good enough images to diagnose and treat the children. And so what you can see in the CT scan is a lot of white that's not supposed to be there. You can see interlobular septal thickening. You can see some areas of ground glass to the point of consolidation. But there's also evidence, so there's another interstitial lung disease associated with trisomy 21 called alveolar simplification. And you can also see that in this chest CT scan. And so it was, again, a complicated picture of a patient who probably had upper airway obstruction, probably has the known underlying lung disease of trisomy 21, but clearly had something more involved. And so based on that, we did a combined bronchoscopy and lung biopsy. The CT scan was abnormal enough. We didn't attempt to do just a bronchoscopy alone to start with. The anatomy was relatively normal, with the caveat I did it through an endotracheal tube. I didn't do a formal upper airway exam. And then her BAL fluid. So this is not this child's BAL fluid. I don't have a picture of it that I'm sure is this particular cases. This is another one of the cases in the series that we were able to mobilize their PAP. But this is basically what this child's looked like. We call it a pea soup appearance. It looked like PAP and had PAS positive cells in it, or free PAS positive droplets. So it was the culture was positive for very, very few Staph aureus, but at such low counts in a non-inflammatory BAL that we didn't consider it to be infected. But all the viral studies were negative, the fungal stains were negative. We don't routinely do PJP PCRs, so can't comment on that. And this is this is some images of her biopsy, and we'll go through a few of her images of her biopsy. And so the picture on the left, you'll have to take my word for it, is a fairly normal looking lung biopsy. There's some evidence of alveolar simplification, which is the interstitial lung disease that some patients with trisomy 21 have, but it's otherwise pretty unremarkable. Not that far away within the same area of lung biopsy, you can see on the right a relatively what I would call a classic PAP appearance lung biopsy. So this looks like a biopsy of a patient with GM-CSF receptor mutation or GM-CSF antibody PAP, where the underlying lung architecture itself is fairly normal. There's very little inflammation of the alveolar walls themselves, but clearly the alveolar are filled with this PAP proteinaceous material. This was also in the same biopsy. So the picture on the left is what I'm presuming Gail Deutsch is going to show you in an hour or so of what this PAP plus like biopsy looks like in these patients. Where you can see it's completely full of either PAP material, highly inflammatory cells to the point where you can't even tell where the alveolar walls are anymore. There's lots of cholesterol clefting going on along, which Bruce Trapnell will tell you is seen in PAP, but not to the same extent that we're seeing it in these children. And so a very, very abnormal biopsy. And then what was special about this case, and why we're calling it sJIA lung disease with a twist, is this patient also had these hyalinizing cholesterol granulomas that were all throughout her biopsy. And this is a picture of just the granulomas. There were multiple granulomas throughout the biopsy that seemed to be reacting to these cholesterol crystals. And we had granulomas at different stages of formation, where the lymphocytes were just starting to coalesce around the granulomas, or around the cholesterol clefts, to where one of these pictures looks like a classic, well-formed, well-differentiated cholesterol granuloma, to areas of kind of resolving chronic granulomas. And so that is something that has not been seen in many or any of these cases to my knowledge. And so in summary, there was non-uniform PAP, but there was this interstitial fibrosis and airspace hyalinizing cholesterol granulomas that was different. There was this reactive pneumocyte hyperplasia, which is sometimes called nonspecific interstitial pneumonitis. There was enlargement simplification of the subpleural air spaces, which is consistent with our trisomy 21, probably not related to sJIA and lung disease, but no fungal or pneumocystis organisms by special staining. And so based on this, we got back in touch with the referring rheumatologist, and because of the granulomas, this patient was started on Humira in addition to the rest of her therapies. And remarkably, we did this about a year ago, and in that time, she's weaned off oxygen, weaned down on her steroids, and actually completely stopped anakinra and cyclosporin. So she's had a very remarkable response in response to a treatment I would presume was related to our biopsy findings.
And I don't know, Randy, do you know, this is Matt's case, do you have any other updates since then? I talked to Matt about a month or two ago about this child.
No, we have another case that was my patient that Matt submitted to Vivian's,
Yeah.
and that kid did very well with Humira as well.
Interesting, interesting.
They also put on, I can't remember if it's pentaminine or back.
Oh, yeah, and, yeah.
And they did that coincidentally.
Yeah, I should say all of these ones, after we've diagnosed lung disease, we start backdrum. All right, so case 2, a surprise. So this is another child with trisomy 21. I'm a 9-year-old boy, also had an AV canal defect, as well as a history of obstructive sleep apnea. So he presented at age 7 or 8, I believe, with 2 months of fever, rash, joint pain, arthritis involving his hand and his knees, His labs of presentation had sort of consistent with sort of an earlier subclinical MAS with a mild anemia, relative thrombocytopenia, some transaminase elevation, very high ferritin elevation. Had a bit of a diagnostic odyssey before he got to us. They're from just up the road in Ohio. Initially thought to maybe have acute rheumatic fever, but didn't get better with treating that. Had some GI symptoms and inflammation, a positive fecal calprotectin. They worried, could this be IBD? Did a CT enterography and ultimately a colonoscopy, which did show inflammation, but clearly wasn't an IBD spectrum. When he came to us initially, had an X-ray that was concerning for a pneumonia with an effusion, but didn't have a cough, wasn't making sputum. Ultimately, we were called and diagnosed this child with systemic sJIA with, as I said, this milder subclinical MAS, and was started on tocilizumab as well as prednisone. However, his disease has never been able to be fully controlled, and he's never been able to get off of steroids in the time he's been treated. So, and again, just sort of kind of going through his history now with the benefit of hindsight, family says, he never fully got back to his normal activity level. Comments in the notes about not keeping up with his friends, but denying any sort of specific dyspnea or shortness of breath. He had a port placed for his infusions, and last summer he had a port infection. He was in the hospital. He had a staph bacteremia, and then based on that, when they pulled the port, started him on IL-1 therapy, first anakinra and then canakinumab, added methotrexate for continued arthritis. Again, in the fall, noted not keeping up with his brothers. Had a really bad winter last winter. Multiple rounds of antibiotics for what had been called locally as a, quote, sinus infection. Multiple respiratory viruses they thought he had. Mom said, when he gets sick, he would just seem really pale. Had another chest x-ray that we have, which was read as concerning for pneumonia with pleural fluid or pleural thickening. And ultimately, because of these recurrent pneumonia/sinus infections/WTF, we had sent him to see Chris in the spring.
Yeah, so they sent me a child who was immunosuppressed with trisomy 21 who was having recurrent pneumonias. At least that's what I started as my paradigm. And drilling down into it, there were recurrent episodes of rhinorrhea with cough, with or without fever. And they were diagnosed with pneumonia based on an abnormal chest radiograph. And then the patient got antibiotics and within a week or two was better. But this is what my clinic is full of, which are patients, some of them with respiratory. This is also the time course for a respiratory virus. It's the time course for sinusitis without lung disease. So it wasn't very specific, at least in what I was thinking. Importantly, they never got a follow-up chest x-ray in between episodes to see whether or not these abnormal chest x-rays, quote-unquote pneumonias, ever resolved. And they occurred every 4 to 6 weeks, which for a child going to elementary school is about how often they get viruses. So again, a very non-specific kind of thing, but sounds like most of my other patients. The physical exam was not very remarkable. There was not obvious clubbing. But because I am who I am and see what I see, I still got a chest CT on him. And so I've got a couple slices of his chest CT, so this is at the level of the carina. And this doesn't look like the other children's chest CT. It's mostly clear. There is something sitting up there in the right middle lobe that's not supposed to be there, but it's not overly impressive. We went down a little bit further, and there's still that thing at the tip of the right middle lobe, maybe something at the tip of the lingula, but again, not overly impressive. The rest of the lung looks very normal and very healthy. Until we get much lower down, and we can see that the right middle lobe has this patchy area. And for those of you who aren't used to reading chest CT, so this thing, that thing over there, the fact that there's these reticulated lines, so there's this interlobular septal thickening. But there's interlobular septal thickening without ground glass opacities, without consolidation. It is almost isolated interlobular septal thickening. And so when my radiologist read this, they actually initially thought this kid had a lymphatic malformation. Because this is exactly what pulmonary, very low-level pulmonary edema or very low-level lymphatic anomalies look like. And patients with trisomy 21 are at risk for lymphatic anomalies. So that made sense to me. This child actually presented with pleural effusions 2 years earlier. Interestingly, we have imaging from 2 years earlier, and this thing is not on there. And so, at this point, I actually sent the kid to ENT to rule out his sinus disease because, again, I thought this may be more consistent with sinusitis than, pneumonia or things like that. But looking at this chest CT, I said, aha, that's what they're seeing. They're seeing this, when you project this into a chest x-ray, a right middle lobe opacity looks like a pneumonia. But because we were concerned maybe it's a lymphatic anomaly, I've always got the ILD in the back of my head, although I didn't think that's what we had in this case. We decided to go ahead and proceed with biopsy when over the next several months, the child kept having this pattern of every 4 to 6 weeks they would get something. And so again, we did a combined bronchoscopy and lung biopsy because I didn't think doing a bronchoscopy alone was going to answer the question. He had, again, normal anatomy via the endotracheal tube through which I did the biopsy. I only did the BAL of the right middle lobe because that's where the disease was. I had very normal appearing fluid. This did not look like PAP. I had a relatively normal differential, although there's a few more polymorph nuclear leukocytes running around. There's more lymphocytes running around than a normal BAL. But otherwise, it was pretty normal. We do lots of viral PCRs. This kid happened to be EBV and HHV6 PCR positive. I don't know if that's relevant or not, but that is what it was. But all of his cultures were negative. And we did a biopsy, again, of just the right middle lobe. So in the first case, we actually biopsied 2 sections of the lung because it was very abnormal. We didn't know what was what. But in this child, since we only had pathology in the right middle lobe, we only biopsied the right middle lobe. And what we found was a biopsy that looked remarkably similar to a lot of these other patients. We found proteinaceous material that was filling the alveolar spaces. There were foamy macrophages. There was interstitial pneumonitis. Basically, that one section looked just like the rest of these cases. And then what was that septal thickening? Well, it was fibrosis. So this is a much lower power view. And on the left is a conventional H&E stain. On the right is something called a trichrome stain, which really brings out fibrin. And all the blue on the right is the fibrin. And what you can see is that the interlobular septal areas are much, much thicker than they should be. And so this kid has pulmonary fibrosis with some features of this PAP going along. And so that's what we were seeing on the chest CT, was that interlobular septal thickening. But again, we did not biopsy any other part of this child's lung. So I have no idea, this is part of the lessons learned. We don't know what his normal appearing lung looks like and whether or not the normal appearing lung would still show this PAP. And again, I washed the exact same area that we biopsied, and I did not see PAP by BAL alone. And even after we got the biopsy, my pathologist went back to my BAL and reanalyzed my BAL and still did not see any evidence for PAP. So in summary, this was PAP, but with the chronic inflammation we're seeing in these patients with sJIA, with this septal and interstitial fibrosis with lung remodeling going on. There was arteriopathy with hypertensive changes, but again, it's in this one biopsy. The kid by echocardiogram does not have pulmonary hypertension. So again, we don't know if this arteriopathy is extensive throughout the lung or only isolated to this one area of this child's lung. And so not knowing what to do next, we did start the child on azithromycin and PJP prophylaxis based on that experience. And now I started looking for this child's interstitial lung disease. So I did an overnight oximetry study to see how symptomatic, subclinically symptomatic this patient is. And this is where, again, the problem with trying to manage a kid with trisomy 21 and lung disease comes in, because it's a very abnormal overnight oximetry study with an average oxygen saturation of 93%, but he also desaturates 24 distinct times per hour, meaning he probably has obstructive sleep apnea that's and he may have some interstitial lung disease, and so we need to do a formal sleep study in order to try and tease out those differences, and that workup is still ongoing.
And so our third case, which we sort of called "Where do we go from here?" and sort of also our kind of tip of the iceberg case example. So this child was a previously healthy 5-month-old. He was admitted for sort of persistent daily fevers and a fairly classic systemic GI rash. Did have some mild finger arthritis. Was initially thought this was incomplete Kawasaki, as many of these patients at this age are. Did get IVIG initially, and then steroids, and then started on anakinra for sort of persistent fever and rash despite this treatment. Had some episodes of sort of early or subclinical MAS, which was also treated with pulse steroids. Had elevated liver enzymes in response to anakinra, so that was held, and then was managed for a long time and did fairly well on chronic steroids, but sort of continued to have symptoms as this was weaned down, and the anakinra was restarted for sort of persistent symptoms. At age 14 months, the child was hospitalized for an MAS flare. was started on cyclosporin for that, and at that time developed tachypnea. The cyclosporin was stopped pretty quickly after that, but the tachypnea has persisted. The child was started on Bactrim as well as tocilizumab for really an inability to wean steroids, as well as this anakinra intolerance. And what that tachypnea then is when we sent this child to Chris.
So taking a more detailed history, there was mostly the tachypnea. And this child was breathing in the 60s, just sitting there in my clinic, hanging out. He did have decreased exercise tolerance with dyspnea on exertion, but this is very, very non-specific, especially in patients with systemic inflammation, and it's made worse if they have arthritis. So trying to tease that out gets very difficult. But there was no other prior history of lung disease to explain this tachypnea. The exam, besides the tachypnea, was otherwise completely normal. Again, he didn't have clubbing at all. And so this is his initial chest CT. And again, I'm doing we do non-sedated chest CTs, on 15 months old. So there is motion artifact. And we won't even, this is actually the second CT scan because we did something completely different on the first CT scan that I won't get into. But and what you can see on this CT scan is not a whole lot. But what you can see is way up at the top, there's these little fluffy things right at the edge that looks like it could be pleural thickening, but this is also a free-breathing chest CT, so there's some not great resolution at the edge. But if you look at the rest of the edge doesn't have those fluffy things, so there's something focal there. But that's it. That's really the only abnormality we can find on the chest CT, and if you go down different cuts, it's not like it's the entire length of the chest CT. And so based on that, we really didn't have much to go on. So we did an overnight oximetry study to see if we could figure this out. And he ranged between 98, but did get down as low as 83, and his average where he sat was 93% with a standard deviation of 1. And so while that's adequate, you don't need oxygen to maintain normal but breathing 60 times a minute and saturating 93% I didn't consider exceptionally normal. We did a cardiac echo looking for pulmonary hypertension because that can cause tachypnea in the setting of a normal chest CT, and that was normal. And so we did a flexible bronchoscopy. Because the chest CT didn't have extensive abnormalities, we decided not to do a biopsy at that time because if we saw something on the biopsy, that would be great, but we wouldn't know if that was relevant because of how not extensive it was. And if we completely missed and got if we got a normal biopsy, we wouldn't know if we just missed the pathology because it's really localized, or if it truly was normal. And so he had a normal, exam by an endotracheal tube. I actually looked at his upper airway with the endotracheal tube in place, and it was normal. I BAL'd everywhere because I was looking for infection and for PAP. And so I BAL'd in 3 different locations. We pooled the sample, and it was completely normal with a completely normal differential of almost all macrophages that were normal appearing under light microscopy. His culture did grow out very few Haemophilus influenza, which is a normal commensal in a kid this age, and if they don't have an inflammatory response in their lungs, we don't really do anything with that information. And so at this point, since he was breathing 60 times a minute and saturating 93% and not growing exceptionally well, we decided to start him on supplemental oxygen, which did seem to improve his tachypnea down into the 40s. It didn't normalize his respiratory rate, but it did seem to help, and we brought his oxygen saturations obviously up to 98, 99%. He seemed to have some improved activity tolerance, so it was a very comfortable tachypnea for him, but he was more active. He was continuing on his tocilizumab, and over the next 9 to 12 months, they were able to wean off steroids, and he was able to grow. But he still had this intermittent tachypnea, and I remember that this tachypnea was timed around the time of his tocilizumab infusions. And so it was very confusing as to whether or not it was the tocilizumab, whether it was the oxygen. And so he fortunately didn't get any respiratory infections. He did not develop clubbing or any other pulmonary symptoms. And we were able to wean on this oxygen, but it was very much an up and down game because I didn't want to compromise his growth. And he was having these intermittent tachypnea episodes, but they were around the time of the tocilizumab infusion, so we had a lot of moving parts, and so I decided to keep my part, the oxygen, stable. And so it was a year later. We repeated it. We repeated his echoes along the way, and they continued to be normal. And so after a year of supplemental oxygen, I said, well, we got to repeat the chest CT because either something has happened or nothing has happened, and we're going to be more confused. And so this is his repeat chest CT. Again, it's non-sedated. And you can see that those little things at the apices are still probably there. Are they actually there? I don't know. I think this kid's official chest CT read is normal. But when you drill down the radiologists, they're like, maybe. I don't know. They're just not willing to commit. But it's otherwise a very normal chest CT. And so the deal I made, still not enough for me to want to biopsy and go through that procedure, unless I knew we were gonna find something. And so the deal I made with the parents is, let's get him off the oxygen. And if he can tolerate coming off the oxygen, then we can feel somewhat better with what we're doing. If he can't come off the oxygen, then we have to have a longer conversation about risks and benefits of potential biopsy in this scenario. And so we decided not to biopsy at the time. We relatively aggressively weaned him off his supplemental oxygen, meaning we took him off basically a half or 3/4 of a liter all the time to off within 6 weeks, which is really fast for us. We were doing overnight oximetries at each stage, and he actually was maintaining his sats at each stage and now he has a normal pulse oximetry study overnight off of oxygen. And in something I still don't quite understand, but I'm happy with it anyway, is that he actually seems to be better and more active off the supplemental oxygen than he was on the supplemental oxygen. Maybe because he sleeps better because he's not tying himself up, I don't know. But he's better now. So I don't understand it, but I'm happy anyway. So what we've learned, at least what I've learned, you can comment, from these 3 cases is there's variability in these biopsy results. That may influence treatment decisions. So I do think that we still need to be getting lung biopsies in these children to understand what is happening in each child individually. I don't think we know enough at this point to presume that this chest CT in this patient population equals this pathology yet. We should always suspect interstitial lung disease in patients with sJIA with any lung symptoms. Be suspicious when somebody is diagnosed with pneumonia. If they're diagnosed with pneumonia, it's okay to treat them like they have pneumonia because that's still maybe what they have, but you need to get a follow-up chest x-ray when they're asymptomatic to make sure that whatever you saw on chest x-ray goes away. You need 2 biopsy samples. You need one from the involved area and one from the uninvolved area, which is a conversation you have to have with your surgeons to convince them to do it. Because obviously doing 2 biopsies doubles the risk of bleeding and doubles the risk of persistent air leak in these patients who already have lung disease. But now I think I've got evidence, and I've got some great surgeons who I think will listen to me, that we're going to start doing this. And you can have PAP without BAL findings. So I don't think a BAL that is negative in the right CT scan appearance is sufficient to rule out PAP in these patients because they don't seem to mobilize their PAP consistently by bronchoscopy, or it's so patchy that we're just missing it.
And related to that, I think Gail is going to say that we call this PAP for lack of a better term.
Yes.
But it's not the same as what Bruce Trapnell would be talking about if he were up here talking about PAP. And so it's proteinaceous material in the pulmonary alveoli, but whether that doesn't equal what we call PAP uppercase letters.
No.
Gentlemen, you have only just 2 minutes left, and I want to make sure you have some types of questions.
All right. And there's the last case and other cases that we've seen that we're not showing you today. There's a very wide spectrum of pulmonary symptoms and probably lung involvement with, to date, an unpredictable course. We haven't figured out what is driving these patients to either get better or not, or if they're just at the beginning of the process and in 6 months or 2 years we'll have more what we're expecting.
Right. Yeah, and especially this last case, I think we don't know whether is this the tip of the iceberg? Is there a lot of patients like this that are only being caught up because of hypervigilance on the part of the family as well as the clinicians? Because my partners are now all bathed in this milieu of understanding this complication. Is this something can we pat ourselves on the back and say that we aggressively intervened and prevented this from happening, or is this the natural history that some people have this little symptoms and then it resolves? We have no clue. But this is the work of a large team at Children's. We work very closely with not just Chris, but several members of his group in pulmonary biology and pulmonary medicine, our radiologists, our awesome pathologists, my clinical partners who are all following patients with this complication, and then Metzdahl, who sent us the first patient we described, and the work of Betsy and Vivian, who have really brought us into this world. So I think, again, we don't have a lot of time, and I don't want to impede on the break, but certainly we're going to be continuing to talk about this all throughout the day. So do we have, are we going to, a couple minutes?
Why don't we do 2 questions?
2 questions, really good questions.
And I would also like to thank the families who allow me to.
We cut Randy off last time, so we'll actually have the first question.
The families who
long
let
as
me
it's a good
stand in
question.
front of them and tell them I don't know what's going on, which I openly admit to them in clinic a lot.
We're going to have T-shirts made that say that.
Yes.
Is your last patient still on biologics?
Yeah, he's still on tocilizumab.
Yeah.
We're going to start weaning the interval. Is that what I hear from Dr. Huggins? Yeah, so we're going to start weaning the interval. So yeah, so he's not had, his labs have looked great on tocilizumab. He's now off steroids for the first time since he was diagnosed. He had some arthritis, to get back to Ed's question of whether this is really sJIA, and I have got evidence, I think, that on both regards, but several of the patients have had arthritis at the beginning, but that's been pretty easy to treat relative to some of the systemic features as well. Again, his arthritis responded well. It was the other parts and having MAS-like flares that were the harder thing to treat.
Yes, I mean, you presented 2 patients with trisomy 21. Everybody presented before a year of age. They have unusual responses.
No.
Sorry.
That was
old.
Case 2 was 7 when he
Okay, so
presented
2
at 9.
patients.
That was the other thing that confused me about his diagnosis, because he wasn't, really
2 patients that presented before a year of age, unusual responses to medicines, unusual complications of the disease. And you don't have to answer this now, this is for the panel. At what point in time are we doing ourselves a disservice by cognitively locking into calling it systemic JA? And are we really just describing a completely different disease, and we just need to be thinking about this completely differently?
Mm-hmm. Yeah, and I think that also gets to this tip of the iceberg phenomenon, right? Is there a spectrum of unappreciated pulmonary disease in the broader sJIA population, or are these guys really different in some biologic way? And we don't know. All great questions, no answers.